Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Stephen Cohn. He's a trauma surgeon. He's author of the book, All Bleeding Stops, Life and Death in the Trauma Unit. Stephen, welcome to the show.
Thank you very much, Kevin. Nice to meet you.
So we'll get into your book in a little bit. I know you have an excerpt on Kevin MD. We'll talk about that, but just briefly share your story and journey to where you are today.
Sure. So, for the past 40 years or so, I've been actively involved in general surgery and trauma, and I have been fortunate enough to run or work in a number of large trauma centers and large surgery departments. And over that time period, I've accumulated, a significant experience. And, what you find often is you're trying to explain to a resident or a medical student the importance of doing this or not doing that. And you like to give them an illustrative example of what happens when you don't follow that protocol, let's say. And so over the years, I accumulated quite a few of these demonstrative stories. And a couple of years ago, at the request of my wife, I sat down and wrote them down, and I aimed them at the lay public as much as the medical community. Obviously, there's a certain interest in the medical community also, but I made them understandable, hopefully, to everyone.
So you've been involved in the trauma surgery space for decades now. Tell me about the evolution of trauma surgery and some of the observations that you made over your decades-long experience.
Sure. So much of what we do in the care of an injured individual, it was derived from the military experience. Mm-hmm. The experiences in combat in World War II and Korea and Vietnam informed the civilian surgeons. So they would come back from their wartime experience and they would apply those techniques and to the civilian population. And one of their observations was that the more rapid transport of an injured individual to care, definitive care, improved outcomes. So we started using better ambulance EMS systems were devised. Air transport was employed to try to move people over long distances or where there was a lot of obstruction to the movement of the patient to the trauma center. The second thing that has evolved over the last 40 years is the development and regionalization of trauma centers, so that now rather than every hospital trying to manage complex injured patients who have been hit by a car, fall from a height, work injuries, whatever, they're brought to regional centers where there's a level of expertise on behalf of the entire staff and resources that can be applied. The other thing that's occurred is a series of observations by a lot of very smart people that certain things work in the civilian sector and certain things don't. And with the experiences in Vietnam, Afghanistan, Iraq, more and more of what we would say was sort of the way we did it based on just the experience of the person with the most gray hair, moved to evidence-based medicine, which I'm sure you talk about routinely on your podcast, mm-hmm. where we try to do more and more of our trauma care based on scientific data. So there's been an improved allocation of resources, regionalization, and expertise at both the point of injury and in the hospital. The other thing, I might make one other point, the role of the, quote, trauma surgeon is quite a bit different now. 40 years ago, general surgeons, any kind of surgeon would do trauma care. Now there's more and more specialization where a group of individuals, usually with what we call a surgical critical care fellowship, specialize in the management of both the trauma patient and people with bad emergency general surgical issues, and also the ICU. So those three things are sort of aligned, and we've been seeing a lot of our young surgeons move to that area of the field.
Your book is called All Bleeding Stops, Life and Death in the Trauma Unit. You have an excerpt from that book on Kevin MD about navigating complex ICU conversations from a trauma surgeon's perspective. Now, talk a little bit about that excerpt.
Sure. So this little mini or subchapter was put in because of the frustration that we intensivists deal with on an almost daily basis, which is that we have patients with complex injuries that are foisted. Well, let's say they arrive in our ICU for our care, but our care or our persons are foisted on a family that was not at all prepared for the fact that
Mm.
grandma or grandpa fell down a set of stairs and has a terrible head injury. So we're sort of not the well-known and trusted advisor to the family that's been caring for them for 30 or 40 years. More rather, we're just some person in a white coat that is in their face telling them that grandpa looks bad and that we need to turn him off or turn off the ventilator or something. So there is an immediate distancing of the family from trusting us, as we call it, the trust Olympics. We're losing. And so we spend a lot of time trying to get to know the families. But this is time consuming, and we have a limited amount of resources in ourselves. But in big ICUs in particular, or any ICU, it's a real challenge. And of course, everyone's heard of someone who had a miracle. Everyone's heard of medical error and that leading to bad outcomes. I've had that in my own family.
Mm-hmm.
And so there's an intrinsic, let's say, wariness of the families to these shiny-faced people that just appear with no warning and ask for them to either withdraw care or consider that grandma, grandpa, a daughter, a son could, in fact, not have a good outcome. And it's very challenging. I don't believe that this is as much a problem in Canada or in Denmark or in France as it is here. I think that our system we have not done a good job of informing the public on how we are doing everything we can, but there are limits to what we can do, and there are limited resources. So one of the things I talk about in that little excerpt is I give an example, I believe, of an elderly man that came in after a big stroke. Mm-hmm. And he was seen appropriately by the neurosurgical service and the neurology service, and they elected to attempt to dissolve the clot in his brain. He was in his 80s. And one of the known complications that happens rarely, but did happen in him, was he had a bleed from the clot dissolving agent actually led to him having a major bleed. Mm-hmm. And he had a massive hemorrhagic stroke. And after a week, he was doing basically nothing but triggering the ventilator. So we went to the family and we said, look, we've done everything. We're doing everything. We really need to do one of two things. We either need to do a tracheostomy and move him to some type of a nursing home situation because he's basically vegetative in a coma, or we need to withdraw care. Those are the two options. There really aren't any other options in that situation, and nobody would suggest that there are any other options. So the family said, well, we know he wouldn't want to be trached but vegetative, but we're not comfortable withdrawing care. So for the next 2 weeks, we had, frequent family meetings trying to, basically convince them that they had to make a choice one way or the other. And eventually they decided to withdraw care. But he'd been in the ICU for maybe 3 weeks. And this is very unfortunate. If he was the only person on the planet or only one in our hospital like this, that's one thing. But we had a half a dozen people like this in the same situation. And the negative consequences are that patients were unable to get into the ICU for ICU care and were essentially in a holding pattern in the ER and in the recovery room, where we know that having inability to access the ICU actually worsens their outcomes. So this is just a frustration, but it's a challenge on our side. And I think the more the public understands, what our challenges are, maybe they'll have a better understanding of the fact that we're not trying to run around and turn everybody's ventilator off because we're tired of taking care of their grandmother or something.
You mentioned earlier that a situation like this would be less common in other countries like Canada and Denmark. What exactly are they doing differently to educate and inform the public so they encounter those situations less frequently?
I think there's a, I'll give you my, I don't have, this is not factual, this is just
Yeah.
like a gestalt. The impression I get is that, of course, in the United States, it's a privilege to be healthy. It's not a right.
Hmm.
In all these other first world countries, it's a right. If you're a French citizen, you have the right to health care. And I think that people have a certain belief in their healthcare system that Americans don't, at least my impression, and that people are trying to do the best they can with the resources that they can, and that there aren't unlimited resources. The attitude here is more that there are unlimited resources, and why would I consider, that they're otherwise? So I think that's the crux of it. I think that, and the fact that the belief that we're not necessarily thinking of the patient first, which is not at all the case, but I think that's a cultural thing. Basically, Canadians believe that people are trying to do their best.
So you have a platform here, and what message would you like to share with potential patients and families that can perhaps mitigate situations that you describe?
Right. I think that, you know, on an individual basis, I don't think that there's an easy solution in America. I think that the solution in America is to have a system where everyone has health care,
Yeah.
where we're not spending, fantastic sums of money on the last few months of life. And I think once it became a system where everyone had health care, I think then people would look at the totality of our resources and consider that we're doing the best we can. We're the people that are caring for their loved ones are well trained, and while they should have high expectations, we're not going to be perfect. And like I said, I've had a personal experience with some medical error leading to the demise of one of my family members, and it's always hard to swallow, but I do believe that everybody was trying to do the best that they can do, and that medications are sometimes mistakenly given or omitted. Judgments are difficult in the critically ill.
So let's zoom out a little bit. Your book is called All Bleeding Stops, Life and Death in a Trauma Unit. That anecdote is just a small part of your book. So tell us, what are some of the other main messages you want readers to come away with after reading your book?
Okay. So I guess one message is, what exactly do trauma surgeons do, and that we're not emergency room doctors, that emergency room doctors are certainly necessary, essential individuals. The trauma surgeons are in the operating room. They're managing the most complex general surgery and ICU kind of patients. That would be one objective. Another would be that this is a very difficult area, a very challenging area. That's why I love it. I mean, because every day there are new major challenges. And so the book kind of delineates a lot of different kinds of injuries and a lot of different management of injuries, and has a lot of stories, some of which are amusing, some of which are sort of tragic. And one of the underlying themes is that so many of our injuries that we take care of are completely avoidable.
Mm-hmm.
That leads us to that little op-ed that I know you had on your site, which is things like seat belts and motorcycle helmets, drunk driving. There may be a way that we as a society can institute some simple things, such as helmet laws, that would dramatically lower the incidence of head injuries after motorcycle crashes, and reduce this huge cost burden that is medical care. Many countries you can't ride a motorcycle without a helmet. In this country, it's commonly done, and it leads to a much higher death rate, a much higher number of patients. You don't just die when you fall off a motorcycle. You end up in a coma, with a tracheostomy, getting tube fed for the rest of your days. And that's something that people don't realize. And they also don't realize that the cost of that is borne mostly by the taxpayers, not by the individual or insurance. So, I don't want this to be about finance, but a lot of this injury stuff is avoidable.
Mm-hmm.
And the most dramatic example that I've seen over the last couple of months is, I live in New York City, And we have all these people riding around on electric bikes and mopeds, electric mopeds that go about 40 miles an hour. Almost the minority have helmets on. And my ICU right now is filled with people with devastating head injuries who were in moped versus car crashes. And they're really in bad shape. This is a fairly simple thing. Require helmets, it lowers the incidence of devastating brain injury dramatically. That's been shown. It's not like they're unaffordable. So I think much of what we care for is avoidable. The other just message in the book is that people that do trauma also do a lot of emergency general surgery, and so that's most of the operating that we do, which is all the appendectomies and gallbladders and bowel obstructions and people who are bleeding to death. At the hospital, the person that holds a lot of the catastrophe stuff together at most major centers are the trauma guys. They're the ones that are in the hospital, kind of like a surgical hospitalist. So, it's a challenging job, and it's very enjoyable, but it can be hard to do.
Now, any misperceptions about that field of trauma surgery that you would like to clear up?
Well, we mentioned the whole spending all of our time in the ER, that concept. I think, within the field of surgery, or let's say medical students, people often feel that, trauma surgeons are the masters of nothing. They're sort of generalists. When in fact, the way we think of it is we're sort of the experts on dealing with catastrophe. So when someone, loses an airway on the floor somewhere, when someone is bleeding to death in the operating room and they need someone to come and bail them out, that's who they call. They call the trauma surgeons to come do that. So I think we're pretty proficient at dealing with a kind of catastrophic problem. And I think that goes with the whole critical care ICU thing. But that's probably the main misperception is, what exactly do we do? In terms of the training, we go through generally 4 years of medical school, 5 years of residency. Then most of us typically do a year or two of critical care or trauma critical care fellowship. And then it's just a matter of gaining experience. Many of the trauma surgeons, general surgeons have a military experience, as I did. And that just gives us a little bit different perspective. Doesn't mean you can't be a perfectly competent or excellent general and trauma surgeon without having a military experience. It just gives you a little different perspective.
Now, for those medical students who may be interested in trauma surgery, what kind of questions should they ask themselves to make sure they're the right fit for the field?
Right. I think just like any area of medicine, first thing you have to decide is, are you temperamentally equipped to be in this area? So one of the things we talk about a little bit in the book is that, there are people who are absolutely essential that do inguinal hernia surgery over and over and over again all day long, and they do an excellent job. They're very competent. They have great results. That's completely controlled in a controlled environment where you know what you're dealing with, the operation, and it's standardized. Dealing with a trauma patient is, I always tell people, after a car crash, imagine this patient was stuffed into a burlap bag and struck by 5 guys with baseball bats, pulled out of the bag, put on a stretcher, roll in the door. What's their injury? No idea. So you have to be able to be pretty nimble, methodical, but nimble, and recognize that the unexpected is just that. I mean, I had a patient once years ago who arrived by helicopter from a car crash. And the story was that he was driving a car, crashed on the freeway. They brought him in. He had a low blood pressure. We gave him a bunch of fluid, and all of a sudden he started to bleed like a shower nozzle out of his neck and his head. And we thought, oh my God, what's going on? And it turned out that this person had been driving a car. The person whose wife was in the passenger seat, riding in the front passenger seat, was sitting in the back seat. And he thought that the front seat people were having an affair. And so at 60 miles an hour, he decided to pull out a knife and stab the driver in the neck, breaking the knife off in the person's head. So, obviously, who can plan for something like that? Where you've got a knife blade
Mm.
sticking in snapped off in someone's neck. Things are very chaotic or potentially chaotic. And we always say that the worse, the sicker the person is, the more chaotic it appears, the calmer that we as trauma surgeons need to be, because the entire team takes its cues from the leader. And so if we remain calm and methodical and deal with the problems that arise without becoming anxious, then the better outcome for the patient. So you have to make sure that you're the right psychological fit for the job. And same thing with any position in medicine. It is a pretty fast moving position, but I always say it's sort of like your Captain Sully landing a plane on the Hudson. Except we have three of them at once
Yeah.
sometimes, and you have to maintain your cool, try to follow your training, have good instincts, and that's something that not everybody enjoys. But if you are a student that enjoys dealing with catastrophe and can keep your cool, then you might consider that. And as a general surgeon, you'll have lots of exposure to it, and people naturally sort of have a natural affinity to it, or they don't.
Now, you've been a trauma surgeon for decades now. You have experience in the military. Have you really seen it all? Do you think that there's any situation in the hospital setting that could surprise you?
Well, it's a matter of sort of degree. Recently, I had, well, maybe 20 years ago, I had the opportunity to train many of the trauma surgeons who run trauma centers in the Middle East: Beirut, Cairo, Riyadh, Israel, multiple cities in Israel. And after the recent events, one of the trauma surgeons there told me that they had received 100 casualties in 36 hours. Sometimes it's a matter of, the volume. Have I taken care of 100 critically ill people in a day? That's a level that I haven't seen. Obviously, you do have times when you have a huge volume, but the interesting thing about I'm sort of not answering your question, but I'm gonna say this. It's interesting. Sometimes it's not so much about the number as the intensity of a single person,
Hmm.
which can keep you, you know, completely doggedly taking care of someone for a long period of time. One of the, and I'm not trying to bring this back to my book, but it just makes me think of this one particular person that we took care of that, we spent the whole afternoon with 20 people working on this kid. And he amazingly survived, but it really was this enormous team that we were, you know, taking care of him, giving him massive amounts of blood and everything else to try and get him through a devastating injury. It's not so much the volume, but getting back to your question, I think I've seen most of the things that folks see. There are always an occasional unique experience, but I don't think I'm looking for to be surprised at this point. I think you want to kind of calmly deal with whatever it is that comes across the door.
We're talking to Stephen Cohn. He's a trauma surgeon and author of the book, All Bleeding Stops, Life and Death in the Trauma Unit. Stephen, let's end off with some take-home messages that you want to leave with the Kevin MD audience.
I guess it's all about injury prevention. That's my take-home message. Wear a helmet when you ride a motorcycle or a bicycle. Wear your seatbelt. Don't drink and drive. One of my colleagues likes to have an occasional drink. He has a breathalyzer in his car. If he gets in the car and he's had some drinks, he checks it. If it's elevated near the limit, he calls an Uber. Don't drink and drive. We still have the same per capita loss now that we did 35 years ago. It's crazy. Try to prevent injuries. And then if someone has the misfortune to have a bad outcome and end up in the intensive care unit, please try to remember these folks are doing the best they can to keep your loved one alive, and give them try to give them your trust and realize they're not the enemy. They're doing absolutely everything they can do to sustain your loved one.
Stephen, thank you so much for sharing your stories, time, and insight, and thanks again for coming on the show.
Thank you, Kevin. I appreciate the opportunity.